Hello and good morning. I'm Dr. David Pedler, Scientific Director of CIMVHR. Thank you for logging into today's symposium, sponsored by the True Patriot Love Foundation. It's called Unpacking Moral Injury, Current Understandings, Gaps, and Future Directions. Before we begin, let's acknowledge the Indigenous peoples of all the lands that we are on today. We are meeting virtually. I would like to take a moment to acknowledge the importance of the land which we each call home. We do this to reaffirm our commitment and responsibility in improving relationships between nations and to improving our own understanding of local Indigenous peoples and their cultures. I will now invite Dr. Stephanie Bellange to introduce the symposium. Stephanie?
Good day. My name is Stéphanie Bellange. Je suis la cofondatrice et la directrice scientifique associée de l'Institut canadien de recherche sur la santé des militaires et des vétérans, ainsi que professeure titulaire au Collège militaire royal du Canada. It is a great honor for CIMVHR to be co-hosting this Moral Injury Symposium with the Center of Excellence on Post-Traumatic Stress Disorders. During the presentation, please do not hesitate to ask questions dans les deux langues officielles. We hope you enjoy this unique symposium offered to you on such an important and novel topic. It is now my pleasure to introduce Dr. Patrick Smith, President and CEO of the Center of Excellence on PTSD and related mental health conditions. Patrick.
Bonjour, and thank you, Stephanie. Before I get started, I would also like to say good morning to most Canadians. I think it's morning. For our friends and colleagues in the UK, good afternoon. And for our diehards in New Zealand, Australia, good evening. Before I get started, I would also like to acknowledge the land of the Indigenous community where I'm presenting from. Stratford, Ontario was founded by the Anishinaabe, Haudenosaunee, Ojibwe, and Chippewa people, and these peoples the territory is covered by the Upper Canada Treaties. I would also like to do a huge shout out to CIMVHR. Everyone here knows that CIMVHR and the annual forum that CIMVHR has put on for many years, over a decade now, it's something that all of us in the field look forward to. It's always been high quality, and I just think that to Dave, to Stephanie, to Lauren, to Stephanie, Christoph, everyone who's been part of doing this pivot and shifting to this new symposium format, it's been extremely successful, and I want to congratulate CIMVHR on their work. I've heard Stephanie say the other day that in many ways the silver lining is that many people who wanted to be part of CIMVHR over the years but couldn't access the forum and maybe couldn't have gotten to Halifax in October, they're able to make it to these symposia. And I think that the work that CIMVHR has done is going to be groundbreaking and moving us forward. I also I'm wearing teal, and teal is the official color of PTSD. It's also the color of veterans who've experienced military sexual trauma. The reason I'm really excited about this symposium on moral injury is because every time I've spoken to and heard from a veteran or struggling with moral injury and PTSD or their family, they talk about how when they first heard about or read about this construct, the light went on for them. We know that there's a lot we know, there's a lot we don't know. And so this symposium is really about showcasing what we know so far, where there are gaps, and where we think we need to be going in the future. I'm also really excited because the way our Center of Excellence is building our organization from the ground up is listening to the voices of people with lived and living experience, and it's doing our work collaboratively. I'm really excited about the panel that we have today. We have some of the top researchers in moral injury in Canada, as well as our partner from Phoenix, Australia. And we have the voice of people with lived experience. The thing is about moral injury, no veterans' voices have been out there consistently talking about moral injury. And while I've talked to many people who can identify with this construct, it's not all the same for all veterans, for all first responders. And it's important for us to remember some people have their connection with moral injury as a construct while they were on deployment at a peacekeeping mission. We'll hear a bit about that from Brian Mckenna today. Others may be as a bystander during the LGBTQ purge. Others may feel that they have resonance with moral injury from a military sexual trauma perspective. I just wanted to make note that we should pay attention, and as we're thinking this through, that there are many different voices, many different experiences, that we need to make sure that those voices are heard, those faces are seen, and we're able to better understand and respond to these issues. So without further ado, I would like to welcome Anthony Nazarov, who is one of the leading moral injury researchers in Canada, who's going to be talking about what we know so far from the military and veteran perspective. So Anthony, over to you.
Hi, I'm Anthony Nazarov. I'm an allied scientist at Lawson Health Research Institute. I'm a postdoc at McDonald Franklin OSA Research Center, and I'll be presenting about moral injury and provide an overview of this topic. So I'll be discussing what is a moral injury and provide an overview of this concept. So what is a moral injury? Why is it important? So what are the gaps that currently exist? What do we currently know? And where do we go from here? So long story short is there is no clear definition of moral injury currently, just because it's still an evolving construct. We do know that many different disciplines have been working on this issue: psychology, philosophy, social work, spirituality, and there is a research to try to get at a more clear definition. But you can think of it as psychological distress or a spiritual wound, a character wound, in response to perpetration, bearing witness to failure to prevent or learning about any event that transgresses deeply held personal beliefs, subjective moral standards, or your belief about what's right versus wrong. So we also know that betrayal could also be an aspect of moral injury exposure. So this betrayal of justice by a person of authority in a high-stakes situation. So this also gets embedded into a definition of a moral injury, or at least what event could precipitate a moral injury. So typically, with moral injury, the psychological and behavioral manifestations include alterations in self-perception, their identity, alterations in moral thinking, what's right and what's wrong, belief in the greater good of humanity, relational impacts, maybe a disinterest in maintaining or fostering relationships, emotional aftermath. Typically, that's emotions like guilt and shame, but it could also include anger and anxiety. Self-harm, spirituality, so loss of purpose in life, or loss of religious or spiritual beliefs. And you can also have symptoms of PTSD as well. So that's why it makes it a little bit confusing. And similar to PTSD, not everyone who's exposed to psychological trauma will develop PTSD. Similarly, in moral injury, not everyone who's exposed to a potentially morally injurious experience will develop a moral injury. And this is where we can make that split between a moral injury exposure and moral injury expression or moral injury outcome. So the potential morally injurious experience, that's the exposure piece of moral injury. And then the expression, that psychological manifestation, that's the moral injury outcome, or typically it's just shortened to just moral injury. So currently it is still an evolving construct. It's not a mental health diagnosis, and that becomes an issue because classic PTSD symptoms and outcome measures don't capture all symptoms commonly associated with moral injury. Also, we can see that some potentially morally injurious events may not always meet PTSD criterion A for diagnosis, so it may not reach a threshold to be diagnosed for PTSD. And all of this is creating a dichotomy in debate, right? We have brilliant individuals on both sides of the camp where for some, it's really a term that finally describes the essence of their own struggle or the essence of the struggle of their clients. But for others, it could just be seen as a subtype of PTSD. But whether moral injury is a construct independent of PTSD is still under debate, but many signs point to yes, but we still have a lot of work to really definitively make that conclusion. So who can be impacted by moral injury? Long story short, everyone. So shame and guilt that are common moral emotions. They're complex emotional and cognitive experiences, and they arise when one perceives their behavior to transgress an internal moral standard. Those challenges could be across the spectrum. So moral injury is on one extreme spectrum of it, but everyone's exposed to moral challenges, and they give us this outcome of moral frustrations. They could be constant frequency, they could occur at a high prevalence in the population, but once we sort of look at the degree of mental, social, and spiritual harm and impairment, we go down to the spectrum where we go into more of moral distress as being an outcome, and then finally moral injury being an outcome in response to not a moral challenge or a moral stressor, but a morally injurious event. So who can be impacted? Going back to this, well, we can, based on that, identify some groups that would be at a higher risk, right? So we could look at different ways to identify the segment of the population. One of them could be occupation. So military personnel, healthcare workers, first responders, individuals in the legal system. So they're all individuals who need to make difficult moralical decisions in high-stakes environments and sometimes under very extreme time pressure. But really, no one's off limits. So why is it important to study moral injury, or at least drive our attention to this construct? It's common, it's linked to poor outcomes, and it's also difficult to treat. We do know that guilt and shame are widely reported in PTSD. PMIEs are common when we're looking at, for instance, deployed TAF personnel to the mission in Afghanistan. Over half the individuals endorsed a potentially morally injurious experience. It's also linked to other adverse mental health outcomes. Moral injury in itself is an adverse mental health outcome, but some other classic typical adverse mental health outcomes include PTSD and depression. We know that shame symptoms are temporally tied to PTSD onset. In a Canadian military context, those who are endorsing potentially morally injurious experiences are 1.5 to 3 times more likely to have past year PTSD, depending on that experience. It's also challenging to treat. So current, typical, and common PTSD treatments may not necessarily be appropriate or effective, and sometimes can just make it worse. We do know that there are barriers to care. So Canadian Armed Forces personnel with potentially morally injurious experiences are 2 times more likely to seek help from civilian healthcare providers instead of military healthcare providers. So this is active Canadian Armed Forces personnel. So we need to understand why. Why are they taking that journey? What are the barriers? So what can we do about it, and where can we go from here? So going back to this depiction of this causal process where you have this exposure to a PMIE and then moral injury afterwards. Well, what we could do is we can treat the individuals who have a moral injury. We can prevent it through early intervention, prevent it through avoidance of exposure to the PMIE itself, and then prevention through preparation. But that in mind, we have to keep in mind some challenges and gaps that we have in our sort of working framework of moral injury. Right now, we don't have a valid method to effectively capture and assess moral injury and moral injury outcomes. So we need to know who we need to treat and whether the treatment is effective if we're developing new treatments, and also if we're testing existing treatments for this subset of the population. So scale development is currently in progress for that. There are ambiguous treatment targets and outcomes, so we need to identify, well, what specific targets are you treating in those with moral injury, and measure those outcomes well. And then help-seeking avoidance. So we know that shame and guilt are already socially withdrawing emotions, so individuals are even less likely to discuss their issues or their experiences. So how can we reduce that barrier? We also know that confidentiality may be an issue for some, whether it's perceived confidentiality issues or real risk, when we're dealing with morally injurious experiences where there are ambiguities, perceived ambiguities between morals, ethics, and the legal system. We need to really identify what rights individuals have when they come for treatment, when they come in for research. Treatment coverage typically requires a diagnosis. Since moral injury is not a diagnosis on its own, how do we provide help to those who need it now and who may not necessarily be able to be diagnosed with PTSD because they're not meeting, let's say, full criteria? And unlike PTSD, there are no animal models for moral injury, right? It's hard to mimic shame and guilt in animals at this time. When we're talking about prevention, early intervention is a great opportunity to potentially have some intervening method to prevent an exposure to actually turn into a negative outcome, such as a moral injury. However, that link between exposure and outcome is very ambiguous at this point, and not all PMIEs are the same. Then we have to also ask, well, what supports are required? Can we make things worse potentially if we do provide some sort of support? And so we really need data on outcome monitoring on that point. Another point is the interval between exposure and adverse mental health outcomes can be lengthy, especially with shame and guilt. It could really fester over time, and it could be years until you have very significant functional impairment. So can we identify prodromal symptoms, and then how do we intervene? Guilt and shame are necessary human emotions. So it's a natural response to a potential moral dilemma. They're dilemmas because they're difficult to make, right? So what magnitude of shame and guilt and emotional sort of reaction is reasonable and appropriate, and for how long? We can also avoid exposure, but then that's not an option for some population segments or certain occupations. And sometimes what isn't perceived to be a PMIE now could be reframed as a PMIE later, right? So we need to understand the impact of culture. And then finally, looking at preparation. So when we're talking about intervention at this stage of the touch points of moral injury, we're really talking about moral ethical decision-making training. The issues with that are there's a long gap between training, exposure, and expression. We also need to understand, well, what are the short-term goals of the preparation? What are the long-term goals of the preparation? How do we measure their outcomes? And how do we deliver the intervention effectively? So in summary, there's a really relevant quote here. So the pendulum of the mind oscillates between sense and nonsense, not between right and wrong. And this is very true for moral injury. It is really all about sense-making. And we could do that through treatment. We can do that through supporting individuals after exposure, and we can prepare individuals to navigate complex moral ethical situations in the future. But to do all that, we also need to ensure that we can measure moral injury appropriately. We can identify individuals who have moral injury versus don't, and really target intervention outcomes and measure those intervention outcomes. We can definitely drive progress by, number one, is breaking the population of study silos. We study our populations due to convenience, due to direct applicability, because we conduct clinical work as well. But really, we shouldn't be reinventing the wheel. If there's research that's been ongoing for decades in the nursing world with moral distress, we really should understand their best practices, the lessons learned, share resources among this community, and really ask difficult questions. Asking difficult questions will allow us to have open debates about where this research and landscape of moral injury should go, because it should definitely not be an echo chamber. And then finally, we need to hear more from the voices of those with moral injury, because having researchers and clinicians drive this could bias it in the wrong way. So thank you very much.
Thank you, Dr. Nazarov. Anthony, that was amazing, and gives us a lot to think about. And it's almost like throwing out the gauntlet about what researchers need to do to catch up to better understanding and responding to the construct that resonates so strongly with veterans and their families. You mentioned scale development, and I know that there's the International MILES Consortium, the Moral Injury Outcome Scale led by Dr. Brett Litz from Boston University. I know we're involved in that. I know you are. And Dr. Phelps from Australia. Can you talk a little bit about that and what you think that's going to mean to the field and to better understanding of the construct?
Absolutely. So with this consortium, again, led by Dr. Brett Litz in Boston, in collaboration with many scientists in Canada, in US, in UK, Australia, what we want to do is create a scale that really captures the outcomes of a moral injury. What we've seen in the past is the early scales in this construct sometimes would create that ambiguity between exposure and expression, right? They would collapse it under one component, but in reality, what we want to do is measure them separately. So this is exactly what we're trying to do. If we're providing treatment, we need to measure whether it's effective. How do we measure whether it's effective? To provide proper assessments. So with this consortium, what we've done is we've really went to square one, to ground zero, to really understand and build a scale according to best practices in psychometric and health scale development. So we had interviews with clinicians, with researchers treating clients who have moral injury. We went to military personnel. We went to clients with potential moral injuries as well. Through those interviews, we've identified themes. Through those themes, we've identified the items that could potentially be in that final scale. And it's really exciting progress that we're making. We have a scale that is almost ready for sort of prime time. So it's this initial version has already been included and tested in several populations, including active deployed Canadian Armed Forces. So for instance, the individuals going in to support the COVID response for long-term care facilities in Canada, in Ontario and Quebec. Also, veterans across Canada have been administered the scale as well, both treatment-seeking veterans who are seeking treatment for operational stress injuries and just individuals in the community. We're also administering the scale and seeing whether we're getting the same sort of outcomes in healthcare workers, right? Because it is an occupation that's sort of in the spotlight nowadays because of the COVID pandemic. So it's very promising because it really opens up the doors to understanding whether treatment works or doesn't work, whether we can identify individuals who require treatment, and who are the individuals that we can target for early intervention.
And so from moving from just experiencing of events to, because as you were saying, not everyone who's experienced a potentially morally injurious event is going to later then express functional impairment related to moral injury. So it's moving from the experience to the expression.
Exactly. So, and capturing that journey. So what are the factors that are associated with poor outcomes? What are the factors that are associated with resilience? So we have many individuals who are still doing well despite that exposure. How can we learn from them as well? And that's something that research should really focus on as well.
And so from your work so far, what are perhaps the subcomponents of moral injury that you understand, whether it's someone who's transgressed something themselves or borne witness, or they have that institutional letdown component? How are they different?
You know what, at this point, it's unknown, because as we're trying to understand what are the outcomes of moral injury, what we're assuming that we'll find is that depending on the type or style of exposure, whether it's an action or an inaction or betrayal by, let's say, institution or another individual, we may have different sort of phenotypes of moral injury expression. And again, when you distill it, moral injury is really about whether I've done something wrong or didn't do something wrong, or somebody else did something wrong or didn't do something sort of right. So many different types of exposures, and what we're assuming is that they may have different types of expressions in the end.
Well, I look forward to more discussion and about this later in the panel. But thank you, Anthony, Dr. Nazarov, and for an amazing opening to our panel.
Thank you.
I'd now like to welcome and introduce Dr. Suzette Bremo-Phillips from the University of Alberta, and who's going to talk to us a little bit more about the experience of moral injury and unpacking it a bit from the clinical application perspective for first responders as well as veterans. Suzette.
Hi, I'm Suzette Bremo-Phillips. I'm an associate professor in the Department of Occupational Therapy, Faculty of Rehabilitation Medicine at the University of Alberta. Consortium that does research, teaching, and service in support of military members, veterans, public safety personnel, and their families. We do a lot of different kinds of research, particularly related to resilience building, as well as delivery and determination of evidence-based trauma therapies to support individuals that have been injured with operational stress injury or post-traumatic stress injuries, such as post-traumatic stress disorder, and particularly in this case, moral injury. We also look at some interventions to help them with post-traumatic growth and transitions to be successful in the rest of their lives if they leave service and when they leave service. I want to, before I start giving a presentation today and follow up to Dr. Anthony Nazarov's discussion around moral injury and his overview, before I embark on a presentation here about different kinds of interventions, both upstream and downstream related to moral injury, I want to just first of all thank Stephanie Bellange and Patrick Smith for the opportunity to present at this symposium on unpacking moral injury, current understandings, gaps, and future directions. I also want to acknowledge a couple of people who have been instrumental in pulling this presentation together, most notably Dr. Lorraine Smith-McDonald, a postdoctoral fellow who works with me in the Highmark Lab and who's helped prepare these slides and this presentation, as well as Dr. Alexandra Heber, the Chief Psychiatrist for Veterans Affairs Canada, with whom I've presented a number of times on moral injury. So many of our conversations have been instrumental in what I'll be presenting. And a number of other people have also been instrumental, and those are members of the research teams from which I've drawn a lot of the different material that we'll be presenting today. With that, we'll embark on a discussion about the clinical implications of and different kinds of applications in service of public safety personnel and veterans around moral injury, and different kinds of interventions that might be able to support them in advance of exposure to a potentially morally injurious experience, as well as potential interventions that might be able to support them if an injury is sustained. So to begin, I'd like to use the analogy of a kintsugi bowl when we're looking at clinical applications for treating moral injury amongst military, veteran, and public safety personnel. A kintsugi bowl is an image, the image that you see in front of you in terms of a bowl that represents you or I if we've been exposed, you or I in our lives. Our physical beings, our psychosocial, spiritual beings that go through various different kinds of life experiences, and at times can be affected by those experiences, both positively and negatively. When we're affected negatively, sometimes our being can be shattered. Our inner core, our existential reality can be shattered. Our core sense of self can be affected. Our identity, our personhood can be really affected. And sometimes that results in us being shattered in many ways, like Humpty Dumpty. And part of the challenge of moral injury is helping to put that person back together again, helping them put themselves back together again and reconfigured in a new way. What's beautiful about kintsugi, this Japanese art form, is the way that it takes what has been broken and actually remembers it back together again using lacquer laced with gold. golden powder or other precious metals to help it become even more beautiful than what it was before. So part of what I'm going to be talking about here is a variety of different ways that we as a community help people mend back together again from a variety of different perspectives, be that from us as healthcare providers, mental health professionals and specialists, spiritual care professionals, community-based members, family members, peers, colleagues, organizations, how we collectively together can help prepare people, help treat and provide some early interventions and some supports and services and interventions if people are struggling in a more complex way. So we'll embark on this looking at just some different interventions in terms of where the state of the science is at the moment. Again, I want to acknowledge Dr. Lorraine Smith-McDonald, who's been very instrumental in preparing this presentation, as well as Dr. Alexandra Heber, the Chief Psychiatrist for Veterans Affairs Canada, in terms of their incredible input and conversations that have led to much of what we're seeing on the screen here. Moral injury has, as we've heard, a continuum. So from potential exposure to potentially morally injurious experiences through to moral dilemmas, moral distress, and on to potentially developing moral injury. So as we're going through, there's different stages and places, different interventions that can be offered at different points of the continuum of development, potential development of an injury, as well as different leverage points that we might be able to help people prepare for an eventuality and or intervene to be able to help them reduce the likelihood of developing, in fact, a moral injury, if that might be the eventuality that could occur. I'm going to talk about different levels of preparedness and also intervention. I'm going to start with the organizational readiness. So the ways that organizations and communities might be able to prepare and ready for exposure to potential morally injurious events. Moral injury can occur at the organizational level in and through betrayals, or at the community level if there's been fractures of relationships, shattered assumptions, stigmatization of individuals, that might cause some injury at a personal level. So some of the things that we can do from a community level, from an organizational level, from a systems and collaboration. The other thing that we can do is prepare operationally. So look at the things that we intend to do, as well as anticipation of potentially morally injurious experiences, help people be trained, put policies and procedures in place, look at psychological safety in various kinds of environments, be that within the community, be that within different organizations and where people might be living and working, so that we create these environments that are rich and supportive, but also anticipate where there can be breaches of trust, where there can be betrayals unnecessarily and potentially unintentionally. The other layer is to look at preparing for supporters that might be working with individuals that are exposed to potentially morally injurious experiences. This can be trained professionals, the healthcare providers that are working with them, spiritual care providers, individuals who are in community groups and organizations, people within the individual's world, family members, friends, colleagues, peers, community members, community agencies, organizational leaders, supervisors, really looking at how all of us can be more prepared and ready to recognize, to be able to refer or treat, and then to be able to receive and support individuals from a trauma-informed perspective. So some of the knowledge that in a graded way, depending on who is needing the support, who is needing what knowledge to provide support for whom at what point in their trajectory, needs to be determined. So some individuals will need very intense, fulsome knowledge of moral dilemmas, moral distress, moral injury, signs and symptoms, different kinds of interventions, trauma-informed care, some helping with emotional regulation, as well as referral sources and how we might be able to leverage the different kinds of community supports and services, family supports and services that would be needed in order to support individuals in a very personalized manner. Assessment skills, being able to screen or triage or assess, to be able to judge what a person needs, who they are, what kind of service they need first to be able to help them along in their trajectory of supports and services, what kind of interventions might be available to them, be that formal supports through healthcare, supports and services through faith-based, non-faith-based communities, spiritual leaders, pastoral care supports, as well as what kinds of supports families and others might need. So being able to have the discernment skills, the clinical judgment skills, the assessment skills. The other skill set is really one of creating an environment, and that's through attitudes, through a trauma-informed care approach, and creating a trusting and non-judgmental, safe environment for the other to be able to be themselves and to receive the kinds of supports and services at the right time that they need. The individual who has been injured also needs to be ready. So looking at different kinds of preparation that we can provide for individuals, as well as different types of treatment interventions that could support them prior to, in anticipation of thinking about moral dilemmas they might encounter in the course of their service or work, different kinds of interventions early on after the development of or exposure to a potentially morally injurious experience, and then also what kinds of things could be offered for individuals that might be dealing with more complex challenges. So in terms of preparedness, looking at exploring through formal and informal means, through psychoeducational interventions, perhaps, morals and values before exposure to potentially morally injurious experiences or moral dilemmas, looking at training and education that's meaningful, integrated, representative of the realities of potentially morally injurious experiences. Some have spoken about high fidelity ethical dilemmas that people might be exposed to pre or within different kinds of service provision or deployment, increasing a moral awareness, as well as just general self-awareness, where someone's values and beliefs, morals come from, and how they might be affected in the course of the types of service they might provide. Enhancing the ability to exercise and practice moral agency and judgment. So enabling people to really be able to think through various kinds of scenarios. Moral resilience training is something else that's been put forward. So looking at the capacity to sustain or restore integrity in response to different moral complexities, confusion, distress, dilemmas, setbacks. So helping people really be able to bounce back in the face of those kinds of challenges, cultivating knowledge, attunement, sensitivity, reflection, agency, and practice. Also creating, enabling service providers, healthcare workers to be who are more morally competent, integrated, efficacious, and effective in being able to make those rapid, quick decisions that need to be made in the course of service, be that in deployment, be that in service provision, in whatever that context might look like. There are a variety of different contexts and modalities by which different kinds of interventions can be offered to provide personalized care to either individuals that have been that might be exposed to different potentially morally injurious experiences, or who might need interventions either early on, early interventions, or at a later stage in their healing journey. So some interventions are offered in different kinds of modes and or different contexts. Some might be offered in a more formal environment within the healthcare environment, within the mental health care environment, within the spiritual care environment, or community-based experiential programs, community-based programs. Some of those interventions can be offered for the individual as well as for families. They can be offered for the supports and the peers that are working with individuals that are affected by morally injurious experiences. So some of these interventions can be offered for both peers, for families, for the individual themselves, for the community, to help people understand what an individual might have gone through. Some might be offered in the context of a group of individuals, such as within a residential program, where a variety of peers might be working collectively on an intervention that might support them in and through treatment for moral injury. Some of these interventions can be offered individually, one-on-one, in person, some online, one-on-one, some through virtual reality assisted modalities, some within groups, some through various applications, psychoeducational interventions, psychotherapeutic, as well as activity and experiential based groups. or programs. So there's a variety of contexts as well as different kinds of interventions or treatments that can be offered, depending on what the individual needs. If it's a matter of connecting again with their community, connecting with other individuals, or doing a deeper dive into some issues that they might need to work through that have been raised in the course of exposure to potentially morally injurious experiences. The treatment or interventions can have a variety of different focuses. This is a slide that just pulls together some key considerations through some of the key leaders and thought leaders who have worked on moral injury. I'm going to particularly focus on the right side column, looking at moral injury and some of the different kinds of things that we might address based on factors that have been identified related to moral injury. So looking at different kinds of impacts, the violation of deeply held moral values and beliefs requires that we target reevaluation, enabling people to reevaluate, reestablish morals, values, and beliefs that they might hold, that they may have held, that might have been affected by exposure to a potentially morally injurious experience, or when they're even considering what kinds of moral dilemmas they might encounter in the course of service. Looking at the shame, guilt, anger, outrage that they might experience, enabling them to have a facility to give voice to moral emotions such as shame, guilt, anger, or outrage, looking at helping them resolve existential or spiritual distress, experiencing positive emotions such as joy, awe, compassion, etc., and how they might be able to work through those different kinds of emotions. So a variety of modalities that help people do that. Also helping people consider what kinds of things, as they're looking at the dilemmas they may face, whether they might actually be a perpetrator or a victim, or they might witness a different experience. And each one of us might be in any one of those positions based on the kinds of experiences that we might face in the course of service and our perception of ourselves in those contexts. So the roles each one of us might play at the time of a potentially morally injurious experience or event. In terms of intervention, some of the interventions also look at reestablishing trust and attachment, reconnection with individuals. So that focus on that we'll be seeing momentarily in the different kinds of interventions that can be offered. So reestablishing trust with self, with others, with the sacred or transcendent, with the world, with the worldview. So restoring all of those kinds of relationships, restoring a sense of self, one's identity, a sense of wholeness, putting that kintsugi bowl back together, helping ourselves be put back together. Forgiveness is a key part of that, particularly if there's breaches of trust, violation, interference that's happened with ourselves. So reestablishing relationships often can require that mending of relationships through a variety of different kinds of means. And with that, reviewing different cognitions, choices, responsibilities, atonement, apologies that might be associated with that forgiveness. And then living congruently and authentically as part of that forgiveness process. Also then relearning the world, reconstructing worldviews, beliefs and schemas, refinding meaning and purpose, re-engaging with the world. So recommitting and re-engaging. Many people who have been affected by moral injury don't have a sense of where to be, how to be, and re-engage back in the world that they've known. There are a variety of different potential interventions that can be introduced once someone has sustained a potential moral injury. So be that moral distress or moral injury more formally and more complex or more specific to a particular event. So our traditional trauma modalities, as well as moral injury specific modalities, some complementary and adjunct modalities, as well as spiritual modalities that I just want to identify. Some traditional modalities that are often used with PTSD and other mental health conditions can be very effective with moral injury, though need to be nuanced and may not hit the target of what moral injury requires. So some of the cognitive behavioral therapy, cognitive processing, prolonged exposure, eye movement desensitization and reprocessing, EMDR, narrative therapies, acceptance and commitment therapy, some of the dialectical behavioral therapy, as well as virtual assisted modalities such as 3MDR, which is an emerging modality that is more embodied and enables us to integrate a variety of different multimodalities to be able to help people both exposed to the trauma that might have caused the injury, as well as work through it. Some MI-specific modalities, some spiritually oriented, integrated cognitive processing therapies, some pastoral disclosure therapy, impact of killing programs, trauma-informed guilt reduction therapy, ACT, acceptance and commitment therapy, specific for moral injury, which is an emerging, an important emerging intervention to be looking at, as well as adaptive disclosure therapy and its new version, the enhanced version. Some of the complementary and adjunct modalities are important to consider, particularly in light of some of the focuses of therapy that I just spoke about. So looking at some of the emotional regulation around anger management, for example, or emotional awareness, self-awareness, some of the dramatic arts, art therapy, more broadly speaking, couples and family counseling, some of the community engagement, volunteering or hobbies or leisure activities, peer support, most certainly to help people reconnect with their community and be within a supportive, understanding environment. Expressive writing, also a very important modality that can be complementary to some of these other interventions. The spiritual modalities are also essential to consider. So looking at some of the program specific, such as building spiritual strengths, that particular program, spiritual guidance and counseling that might be received by members of an individual's community, faith-based or culturally based community, connection to the spiritual and religious community that an individual comes from or is rooted in, spiritual and religious worship and practices within a community context or individually engaged upon. Some of the prayer and meditation activities that an individual might engage in, mindfulness, purification and healing rituals, nature practices, storytelling, lament practices, some of the grieving and grief processing, as well as forgiveness practices and self-compassion. So there's a variety of different kinds of modalities that can be integrated across the continuum of injury that someone might have sustained, or distress or dilemmas, and what might be appropriate for one person at one point in time may be appropriate for another or may not be. What someone requires may change across their trajectory as well. So what we need to consider is really what kinds of things we need to look at to prepare people in the eventuality that they might be appropriate, delivered by whom, and that's very personalized for the individual as well as for groups and the context within which that injury happens and the type of injury and source of it. So I'll leave it at that for now. Conversation.
Thank you, Dr. Beaumont-Phillips, Suzette. You know, one of the things that, and we've gotten a few questions from the chat about this as well. We know that in Canada, there are researchers from many different universities and some from the OSI clinics across the country that are specifically studying moral injury and various aspects of moral injury. And we have an emerging community of practice, as you know, for researchers doing that work, hopefully to try to make sure that we can collectively figure out where the gaps are and really support some collective action in this area. There's also, though, a community of practice on military sexual trauma and moral injury that's specific, and it's been developed probably over a year ago in the early development from Drs. Margaret Mckenna, Ruth Lanius, and Alex Heber, and also Rosemary Park, who is very involved in that. And I know you're involved in that community of practice. So can you speak to your observations, perhaps, of where moral injury may be very specific for experiences with military sexual trauma, and also if there are any kind of new and emerging treatment interventions that have focused more in that area?
Certainly, thank you for the question, and an excellent question. The community of practice in general has been a fabulous opportunity to bring a whole bunch of different perspectives together and to really open up a conversation around what moral injury is. in general as it applies to a variety of different populations, certainly those who have experienced military sexual trauma, a specific component of it. So looking at ways that people might have been injured through exposures, breaches of trust and breaches of relationship, potentially betrayals that they've experienced in the course of the injury that they've sustained. So the types of different interventions that we've been looking at have been broad, from bringing people together, from researchers and the community together, for the community to actually be able to respond in an appropriate way, to understand what they've gone through, what ways they've been injured from a morally injury perspective, as well as the types of services that have been offered to them, the types of service gaps that exist, ways to bring people together. Some of the service gaps are fairly broad. We don't have a lot of different types of interventions that are targeted specifically for treating moral injury in the course of military sexual trauma, or not solely within the military context, but in broader contexts as well. One of the emerging interventions that we're looking at right now, and that the Edmonton Operational Stress Injury Clinic is trialing, is a group for individuals that have sustained an injury. So looking at how moral injury might be woven into that experience through betrayals, through what people have witnessed, through what they've experienced themselves, and then looking at the ways to mend it. So looking at restorative engagement that might be able to help people in and through that process of restoration of relationships, not just with themselves and with someone who might have caused the injury, but also with the broader community and with the organizations within which that injury might have been sustained. Does that answer?
Great. That's great, and hopefully we'll have more time to unpack it even a bit more during the panel. But Suzette, I've heard you speak a lot about resilience, and there have been questions from the viewers about resilience. And one of the things I've liked about the way you've talked about it is sometimes when we talk about making individuals resilient, some people can think about that as being a little bit going down the rabbit hole of victim blaming. And you talk about resilience from a much broader perspective. I wondered if you could share your perspective on that.
Yeah, thank you. So resilience often gets referred to from an individual perspective. And if people aren't resilient, a sense that it's their fault that they weren't resilient, or didn't have the tools in their toolbox, or weren't constructed in a way in their being to be resilient, when that isn't necessarily the case. In many situations, we could take the most resilient person, however we define that, and put them in a particular context, and within that context, any one of us would be potentially injured. So rather than looking at it from an individual perspective, looking at it from a socio-ecological perspective, where we look at the individual, the teams, the families, the organizations, helping the organizations support members to be as resilient as they can be, and being truly a safe environment within which people can work and function and live and contribute and exercise their gifts in whatever way that they can. For the support of the organization. So looking at resilience building from a micro, meso, macro level, if we will, the individual, the community, those that serve them, the leadership and the organizations, and making sure that people have the supports and services that they need in place. I think the other piece about resilience is really looking at, with many of these things related to moral injury as well as resilience, drawing on the rich traditions that we have, the rich cultures, the rich perspectives, that this isn't a new concept, either resilience building nor dealing with moral injury. This is something about our human experience. So really drawing on the wealth of knowledge that we all have for resilience building, and that's been building cultures, building communities, restoring people. So drawing on much of the psychoanalytic, much of the psychospiritual and cultural traditions.
Thank you for that. And so again, very much looking forward to the panel to explore that further. And again, thank you for your work, the work of your colleagues at Highmark, and for being part of this panel. Thank you.
Patrick.
I'd now like to introduce Dr. Andrea Phelps, and excuse me, a very special shout out because it's very late in the evening in Melbourne, Australia. We had the opportunity to work with the Phoenix Center for Post-Traumatic Mental Health in the rapid synthesis of what we understand from moral injury from military and veteran perspective, and to quickly apply it to the healthcare environment and vis-a-vis COVID. And so without further ado, I want to introduce Dr. Andrea Phelps.
Hello, my name's Dr. Andrea Phelps. I'm the Deputy Director of Phoenix, Australia, and delighted to be part of this symposium today. What I'm going to be speaking about is the Moral Injury Guide that we put together with the Canadian Centre of Excellence in PTSD. I'm really grateful for the opportunity to work together on this. The Moral Injury Guide brings together a lot of the research that has been conducted in the short period of time since COVID began, and also draws from the broader traumatic stress field. When we talk about moral injury, I do want to start off by just giving a little bit of background about the nature of moral emotions and the range of moral stresses. I'll then talk about moral injury specifically in relation to healthcare workers, and talk about the framework that we developed for managing moral injury and the importance of having a whole of organisation approach. And then I'll go through considerations at the level of the organisation, the team, and the individual. Unlike basic emotions like fear that are about our personal survival, moral emotions are essentially social in nature, linked to the interests of society or other people rather than just our own survival. And they arise when our values or our sense of right and wrong are challenged, and they've been described as the guardians of moral order of society. Different types of moral emotion. When we feel that we've done something wrong ourselves, we're likely to have feelings such as guilt, shame, or embarrassment. When we feel that someone else has done something wrong, we might feel contempt, anger, or disgust. Importantly, there are also positive moral emotions. So emotions such as pride, gratitude, and compassion, still social in nature, but on the positive valence. Brett Litz and Patricia Kerrick have described a very useful way of thinking about the range of moral stresses. So we talk about potentially morally injurious events as being at one end of that continuum, but they really do range from what we'd consider moral challenges. So in the context of COVID-19, that might be, an example would be when we see someone flouting social distancing rules. We might feel frustrated about that, frustrated or annoyed. Slightly more, and those sorts of moral stresses are quite low in severity, but high in prevalence. Further down that continuum, we have what we describe as moral stresses, where people do feel a degree of moral distress, and it might be a little bit more long-lasting. An example of this is a tension between wanting to help others in the context of COVID, but not wanting to put oneself in harm's way. And then at the more severe end of the spectrum, high severity but low prevalence moral stresses are what we would call potentially morally injurious events. And an example in the COVID context is where healthcare workers have had to do things like prevent family members from being by the side of a dying relative. We do, similar to in the trauma field, we talk about potentially traumatic events. We do talk about potentially morally injurious events. And that is because everyone's not going to respond in the same way. So it's recognising that individual variation. There are two mechanisms of moral injury that have been identified in the literature: moral transgression and betrayal. So Brett Litz was the first person to really talk in detail about the transgression of deeply held moral convictions. And Jonathan Shea, back in 1994, talked about betrayal in high-stakes situations. So these are the sorts of events that can lead to moral injury. When you did something or failed to do something that went against your moral code, or you saw someone else doing something that went against your moral code, or you felt betrayed or let down by someone you trusted, or someone in a position of authority. In relation to healthcare, we know that healthcare workers are trained and operate by the moral or ethical code of putting their patients first and, most importantly, doing no harm. When the care that they provide is compromised, they're likely to experience that as a moral transgression. The sorts of circumstances where that might occur is where there are systemic problems that have an impact on patient care, for example, hospital budgets, or where there are uncontrollable situations that lead to death, for example, working in an organ transplant area where you haven't been able to find an organ donor and a patient dies. In the context of COVID, working in circumstances where the demand for resources exceeds supply. Also, where there are circumstances where someone makes an unintentional error is another circumstance in which a moral injury could arise. And then betrayal as a mechanism for moral injury is also relevant in healthcare, where people may feel betrayed or let down by their organisation or government decisions. For example, where there's inadequate availability of PPE, or where decisions have been made about public health measures that people feel then compromises their safety. I spoke before about the range of moral stresses from low to high severity and the range of psychosocial, spiritual impacts that can follow, from frustration that can be quite fleeting through to distress, which is more of a concern, through to moral injury. We're talking here about the most profound and enduring impacts across a range of domains. So it can include feelings, guilt, shame, anger, sadness, anxiety, disgust. It can also include thoughts and beliefs about oneself. So when someone sustains a moral injury, they may experience lower self-esteem, more criticism about themselves, have some fundamental beliefs about themselves being bad, damaged, unworthy, or weak, and engage in self-handicapping behaviours. It can also have an impact on thoughts and beliefs about other people. So often people will describe a loss of faith in people, a lack of trust in authority figures. And then it can have some fairly profound impacts at an existential or spiritual level, including a loss of faith in previous religious beliefs, or no longer believing in a just world and the nature of humanity. So as I say, some fairly profound impacts at this most severe end of the spectrum. In thinking about a framework for the management of moral distress in healthcare, it's really important that we recognise that moral stresses can't just be designed out of the work. They are inherent in the workplace during the context of a pandemic. There are always going to be moral stresses, moral dilemmas. We do believe that the onus is therefore on organisations to implement a preventive and early intervention approach rather than just waiting for problems to arise and then reacting to them. And in order to do that, it's really important to be informed by the literature on what are the risk factors for developing moral injury. And of course, a lot of research is still underway, but to date, what we understand the risk factors to be the loss of life of vulnerable people, a perceived lack of support from leadership or from family and friends and society more generally. When people are unprepared psychologically, that seems to place them in greater risk, and being exposed to additional trauma. So that notion of an ongoing exposure to trauma and to potentially morally injurious events. Why is a whole of organisation response recommended? Drawing on the existing evidence in stress and trauma management, we know that individual factors can influence our responses to stresses, but just as important are organisational and social factors. At the level of the organisation, how well prepared are organisations? How effectively are they able to manage exposure to potentially morally injurious events? What can we do to build strong leadership and to enhance team cohesion? And again, at the team level, based on what we know in the context of trauma, social support is a critical factor in recovery after exposure to these sorts of events. And social support we should think about at work as well as at home. Also, we know that peer support is important from research that's been done with trauma more generally. So starting with the policies and procedures of healthcare organisations, it's important to ensure that staff have clear rules and protocols to follow so that this reduces their need to take individual responsibility for ethically and morally difficult decisions. And related to that, it's important where possible that workers who are not involved in direct patient care are the ones who are making those decisions. It's important for organisations to monitor levels of exposure and where possible to rotate people through high and low exposure roles. To establish peer support programs, and a lot of places do have peer support programs, which is fantastic, but we do need to make sure that those individuals who are involved in peer support have an understanding of moral injury as well as other stresses more generally, so that they've got the capacity to respond to those sorts of issues as they arise. And at an organisational level as well, we need to ensure that there is timely and easily accessible access to psychological and also spiritual support if that's what the individual requires for frontline workers. At the level of the team, how do we equip team leaders to do their best to support staff? For some, this might come naturally, but it's important to provide guidance and training in having sensitive conversations. So ideally, what we want team leaders to be doing is to support staff through frank discussions about the moral and ethical challenges that they'll face, to be aware of the potential for avoidance. If someone is experiencing feelings of shame or guilt, it's going to be difficult for them to come forward and look for help. So important for the team leaders to be prepared to reach out and proactively offer support. And when they do that, to assist staff to focus on aspects of the situation that they can control, acknowledging that they can't control everything, but focusing on what they can control. And also helping them to give meaning to events in such a way that reduces feelings of powerlessness and reinforces the mission, the sense of purpose and self-efficacy. Why is it so important that we're doing this work? What are we achieving through doing this? And there are also things that individual healthcare workers can do to protect themselves. It's important that individuals increase their recognition of moral stresses so that they recognise it when it does occur and understand the potential range of impacts that they might experience. when an individual is confronted with a moral stressor, it's really important that they think it through, try to make meaning out of it, talk to other people if they need to do that. But what we don't want people to do is just to avoid thinking about it because it's uncomfortable, or just to dwell on difficult emotions that they may be experiencing, such as guilt or shame. As I mentioned, for some, it might be psychological help. For others, it might be peers. For others, it might be some sort of spiritual advisor or guidance, whatever works for the individual. We also think it's really important for individuals to take responsibility for engaging in self-care, both within and outside of work. Basic things that we all can lose sight of, but maintaining social connections, eating well, exercising, taking time out and getting sufficient rest. All of these things, as I say, that we can take for granted, but we can often fail to do for ourselves, even though we recommend it for other people. And coming back to the positive moral emotions, these are also social in nature, linked to the interests of society rather than just the individual. We can all support healthcare workers by helping them to experience the positive side of moral emotions, recognising their compassion for others, encouraging pride in their work, and expressing our gratitude as a community for the critical role that they play. Thank you very much.
Thank you, Dr. Phelps, Andrea, and welcome to the panel. Can you remind us again what time it is in Melbourne? Oh, you're muted, I think, Dr. Phelps.
That's a good sign that I'm starting to get tired. It's 2 o'clock in the morning, Patrick.
Okay, so this is definitely a clear sign of how passionate you are about this topic. And I know, Andrea, that pre-COVID, pre the pandemic, your work in moral injury was very much focused on military and veteran. And as I heard one veteran in Canada say to me, it's hard to study moral injury as it's happening, as people are experiencing potentially morally injurious events. He said, in his words, it's hard to kind of study me in vivo while I'm dodging bullets in deployment. But he noted that we have a natural living laboratory with COVID and with the pandemic, with healthcare workers and the challenges that they've gone through, but are still going through. And so can you speak to, he talked about having an opportunity and an obligation to do a deeper dive and in hopes that what we learn will have translation back to the military and veteran context. Can you speak to that?
Yeah, no, absolutely. I think it is a unique opportunity in that way, Patrick. It's in real time where we're trying to do this research now with people in healthcare settings. We don't know what the next months are going to hold for us, so it is an opportunity to do the research while it's happening. We don't know, as everyone speaking before me has highlighted, this is still an emerging area. It's still something that we're learning about. Most of the research to date has been in the veteran population, so we're starting to get an idea of the sorts of morally injurious events that veterans are exposed to and the sorts of impacts and outcomes. We're still learning about that in healthcare workers, and what we learn here will no doubt change our views about the nature of moral injury and possibly open our eyes to different ways of thinking about it, different perspectives. But ideally, it will also give us the evidence that we need about what we can do while it's happening or shortly after it's happening to prevent or intervene early when people are starting to develop problems.
And everyone understands that communities and citizens have a role to play in squashing the curve for the COVID spread. And yet healthcare workers or organizations internationally have been talking about anticipating increased PTSD and or moral injury among healthcare workers because of what's going on and what they're experiencing. And I think, to your point, the focus on organizational supports and considerations that can actually, instead of sitting back and watching what happens to healthcare workers, what can we do right now to squash that curve? Then minimizing the number of healthcare workers who have exposure to these potentially morally injurious events, translating into needing clinical services.
No, that's absolutely right. And this is why we really argue for that whole of organisation approach. We can't just say it's up to the individual healthcare workers to, boost their resilience or whatever. If we know that there's an inevitable exposure, what can organisations be doing to help to manage that? And that's where the Moral Injury Guide sort of, based on fairly limited evidence at this point, we have to acknowledge, and drawing on the research from trauma more generally, but thinking then about what can organisations do to be protective of the workforce. And really that is about recognising in advance the sorts of situations that people are likely to find challenging, and helping them to find the language, to give them the opportunities to process, to come to terms with, to make meaning out of the experiences that they're having, and to bolster the sort of team support and the cohesiveness within teams, because we know that can also be protective.
And we've certainly heard from healthcare workers that it's that very thing you just mentioned. It's the meaning making. It's that you might not be able to prevent my exposure, but if I know that I have supervisors, team members, and my organization helps me to understand the ambiguity, help to talk about it, that I'm not alone, that the supports that the organization can put in place has a huge impact in the individual experience.
Yeah, absolutely. And the nature of moral distress, when people are having feelings such as guilt and shame, it's very hard to come forward, to put your hand up and start talking about that. So for organisations to be proactive, reaching out to people and really acknowledging the distress that they may be experiencing, just to really help them to start to talk about it.
All the groups that we're working with, whether it's military, serving military, veterans, first responders, or paramedics, or healthcare workers, they're all used to taking care of others before they take care of themselves. So I think that's another reason why your focus on the organizational and team-based considerations are so important.
No, I agree. Yeah.
Thank you, and I look forward to more conversation about this in the panel later. Thank you, Dr. Phelps. And thanks for sticking with us for into the wee hours of the morning in Melbourne.
No problem.
I'd now like to introduce Brian Mckenna, and I've had the good fortune to be able to hear Brian's talk about his own personal experience with moral injury. And he's someone that can talk about personal experience with combat stress PTSD that is more well understood, but also from a few different deployments, peacekeeping missions, really resonating with the construct of moral injury. And for me, what has been so incredible is how the moral injury also impacted his journey and his treatment experience for PTSD. So without further ado, I want to introduce Brian Mckenna.
Good day. So my name is Brian Mckenna. I'm a retired warrant officer from the Canadian Armed Forces. I retired in 2015, and I have the pleasure of working now at the Center of Excellence for PTSD. The Center of Excellence, of course, is in Ottawa. I, however, am talking to you from Delta, BC, my home, which is on the land of the Musqueam and Coast Salish peoples. So For me, it's a nice day outside, but I'm here to talk to you about something that's been a bit of a challenge over the last couple of years for me. And we're talking, of course, about moral injury. I do suffer from post-traumatic stress disorder. I was diagnosed with complex PTSD. And at the very beginning, it was linked to trauma, as in linked to specific events. I found myself at a place in life dealing with the Medicare system where I could literally show people on the calendar where the problems were when we were talking about trauma. On this day, this event happened. On this day, it went this way. This was a bad week. That was a great month. That was essentially the way I was approaching things and the way they were approached to me, because we were looking for what the problem was based on an event, and we were trying to work through that. It took a long time, a couple of years in, before we started to actually put the finger on what it was that was the problem. So why is it today that a lot of the details actually of some of the events, they are fading? I run into other veterans that were at certain events and we forget stuff. We remember it clear as day. But as we speak to each other, we have that realization of, oh, okay, yeah, I forgot about that detail. But there's a place in my memory where those things have not disappeared at all. And it tends to be the ones that I had an attachment to. So I've spoken before to folks on this very topic about what it was like for me when I was in Yugoslavia, and the certain circumstance that came to mind. There were a number that were slightly scary, slightly challenging to deal with, a little bit of aggression involved. Those ones, though, don't stick with me. Most of my memories from there are rather positive. But there was one in that mission in Bosnia where there was a situation of having to deal with old people that were starving. And to me, it connected to my grandparents back home. And that was just a connection of feelings that I took years to sort out. For other people, they don't even remember that day, but they remember others that registered with them for some reason. So I've noticed that over my own history. And one of the things that I want to speak to you guys today about is there was an event when I was working for NATO. I was a civilian contractor working in NATO, and we were in the north of Afghanistan in a town called Mazar-i-Sharif. And the details aren't so important, so I'll just get through them fairly quick. At the end of the day, we were teaching police officers from Belgium, Germany. There were some Croatians and some French police officers there. And we were teaching them basic counter improvised explosive techniques. In other words, how to avoid getting blown up. And in that context, these police officers were mentoring the Afghan police and wound up searching vehicles and doing jobs like that. And in the process of that, they would come across other crimes that they had no ability to do anything about. And one was many, many cases of child trafficking. So I would be teaching these police officers, and we would be trying to talk to them about the job we had at hand, how to recognize that a vehicle might have explosive in it, or someone had actually turned the vehicle into an explosive. These officers weren't particularly able to get into that level of training because they'd just been through a moral injury of their own, as I would understand it now. At the time, I didn't really know what we had to do to solve that problem. I didn't know how to get them to the next step. The next step was we needed to just progress with the training that they were doing. What was holding them back was some of them were dads, some of them were fathers back home, they had young siblings, something along those lines was just making them realize that they couldn't actually focus on their job because they had this other thing that they could do nothing about. And that's kind of where, in this discussion for me, the details end and the feelings kind of take over. The feeling that these officers had, and then we had as we witnessed the same things ourselves when we would be out in the public, it was a feeling of futility. I can still feel it now. I can still feel, as I'm speaking to you, those moments of feeling like I'm here with the most highly trained people in the world. I'm here with all this equipment. There's no lack of want of money or training or power. We had that, but none of those suit the situation that we're dealing with. I don't have the authority to stop that problem. I don't have the ability to intervene. And in that case, what happens to a lot of soldiers is they find themselves in a situation where they become armed witnesses to bad things. We have to remember that when we deploy soldiers, they go in very tight confines of rules and regulations. They don't go to fix whatever they encounter. They go to do just what the mandate is and abiding by Canadian law the whole time, the code of service discipline at the whole time, and the orders as they come down. And so that can put you in a really tight box where you have to see things like people that are starving, but you can't give them food. People that are hurt and wounded that are coming to the gate of the camp, but if we start turning our camp into their hospital, we'll create a humanitarian crisis. So we can't do that. And all these situations that happen where what we are trying to do in the grand scheme of things is to get their country up and running, to get their aid agencies doing what they should do, and that the people naturally go to them for those things. But in the process of that happening, which can take decades, they look to us and we're not in a position to help them. I know from speaking to a number of different soldiers that are out there that that's one of the things that stays with them over time. And what exactly is that? And as we speak about moral injury, we're starting to get around to the real discussion with some of these people. And for me personally, as to what is the thing that you've been trying to tell me on that doctor's couch for the last couple of years, I find that we've been speaking about moral injury just in the press a little bit. We've certainly been doing some work at the COE. And my personal social media is constantly being lit up with people I either served with 25 years ago or people from conflicts going back to the 60s, 70s, and 80s that have come forward and said, okay, now I've run into someone that's talking what I'm talking about. We also have to remember, I think, that things like this that are challenging, it's real easy to tie them to deployments, and it's not necessarily wrapped up in a deployment. It's wrapped up in who you are as a person. If you're forced to witness or do something that conflicts with what you feel and hear, that creates a bit of a moral dilemma. And even though you're a professional and you're going to do your job, you're still the father, the daughter, the son, the human being that's got to execute that. And so while I talk to you about people have come out of the woodwork and reached out to me from missions, like we've had a couple from Rwanda have come forward, there's also been people that had to work at the Swiss Air Recovery. There's also been people that have worked in a government institution for decades and feel that that institution doesn't have their back. And that then makes them reconsider and challenge some of their own thoughts of, well, was I supported? Was I part of the team? And those things you can't find on the calendar the day that that happened. You can't ask me what day it was hard to not feed people that needed food. You can't ask me to tell you what day it is that I felt child trafficking was bad in Afghanistan. Every day, right? But the days that posed me bodily risk, 3. And that's the reality that I think we need to be talking about more. And I'm glad to see that we are talking about more. So I will wrap up with that. Moral injury for me took a number of years of dealing with me and my doctor. And my doctors were trying, and they were working with me, and I was working with them. I was honestly answering the questions that they were putting in front of me, but they weren't asking the right ones, and I wasn't able to put my finger on what the thing was till years later when one of my doctors started approaching it in a new way. And then we started to get to the bottom of what actually bothered me about some of those events. And when we look at it as Brian the person, then we start looking at it as, well, maybe it's not those events, maybe it's the situation. I know for now, when I look at things that are happening in countries like the former Yugoslavia or Afghanistan today, and I see things that happen today that I think are not positive, even then, it's not a doubt, but it's a reoccurrence of those emotions come forward. And that can be a struggle. It can be a struggle if no one out there is talking that language, even if they're doing their best to help you. So that's the situation that I found myself in. I found myself getting tons of care, but the care wasn't asking the right questions. It wasn't scratching the problem that I had. And the problem I had was the job I did as a soldier, but I was still a person doing it and still feeling the things that an average person would feel at that time. So with me, at this time, I think that's the right time to wrap up, and we'll proceed from there. Thank you for your attention.
Thank you, Brian. And, every time I hear you speak about this, I learn something new. One of the things that really strikes me every time I hear you talk about that is when, and I've heard it from other veterans as well, now someone is talking about what I'm talking about. Now someone is putting words to something I've been feeling. So can you elaborate on that and a little bit about that from your perspective and your colleagues that you've actually talked to about that?
Thanks, Patrick. So I would say for me, I guess naming it or calling it validation is kind of where it was at for me. When it gets named, when someone says to you, we're going to start working on this, perhaps you have this, that gets my brain into a place of going, okay, this is a thing, whether it's moral injury or a sprained ankle, you want to know that someone's on the file. And I think that's the first piece of comfort I could find in this situation was, okay, this is named. That means somebody knows about this. Then perhaps someone's working on this, and there might be a path for me to walk down. And I even find, outside of the doctor-patient scenario, just me as a peer and as a vet speaking my mind, that's why people are reaching out now and connecting, is because they saw something a month ago that made them feel there's one other guy out there who gets me. And that proceeds where it does. I think a lot of it too is the soldier Brian and the person Brian went and did these things. One human being, but both versions of me went there. And I didn't leave the dad in me at home when I went. I suppressed it and certainly functioned out of the uniform and the rules that we had. But that was a lot of it for me, was both people went, both people saw and had to not do things. And I find that those stuck with me the longest. But I'll wrap that answer up there, is that for me, knowing it's a thing gives you hope that there's stuff you can do about it. And even if we're still in the position of talking to each other about what those things are, well, good. We're past the start point then.
That's right. And, it's really compelling when, some people have the experience that they have moral injury, but they don't have more classic fear and anxiety-based PTSD from combat stress. You're very clear that you have both, that you have, you talk about the sound of the freezer door in the freezer aisle at the grocery store can trigger something that sounds like a mortar going off. And to take cover, if it's a mortar going off, is very adaptive, and maybe not so adaptive in the frozen goods aisle of the grocery store. Can you talk a little bit about how that they can interact for an individual?
Right. So my situation is essentially this. If someone were to do or say or cause something that made my anxiety peak, or my fight or flight hypervigilance, as you call it, you could bring that on in an instant, and my body will react before I have time to think about it. That's not what moral injury does to me. Moral injury doesn't smack me in the face in any way or just launch at a peer to me. It builds over time. I've learned that watching the news before I go to bed is a really bad idea, because what I don't need to do is start re-exposing myself to what's wrong with the world. Now, I know those things are occurring, but I have learned that it's not so much, moral injury for me isn't so much an abrupt hit, but it does have its peaks and valleys. And sometimes my own actions cause those peaks, right? And so that's really the difference. You know, I would describe a moral injury, a sense of it, as a constant nagging feeling that comes up and down. And it goes up and down on a lot of things. Like, one of them we've spoken about, which I'm happy to share here, is, you know, I went to 2 different countries that were war zones. One's doing better than the other. So if I see a story on the news about the one that's going better, it makes the things that happened there that bother me less. And when I look at the one that's going worse, you know, like I said, going to bed and reading about a bombing in the town I served in is not good for me. And that isn't because it's triggering at the moment. That's because it makes me reconsider and ruminate and function in that way.
Mm-hmm. Well, and I'm really looking forward to more discussion about this, and particularly giving some thought to, given how impactful it is for someone to start asking the right questions and start talking about it from a different perspective, what we can all learn in terms of the exploratory approach with our individual clients and everything, to really make sure that we can open that discussion, if it's a discussion that needs to be opened, at a much earlier stage. So I think at this time, thank you so much for this. And now we're moving into the panel discussion. So hopefully we'll do a deeper dive into that. Thanks, Brian. And I think we're, yes. So lots of interest, and thank you all for your contributions. There's a lot of interest in this topic. And one of the themes of a lot of the questions that people have been asking is to try to locate this vis-a-vis. Is it a subtype of PTSD? Does it need to be completely separate? What is the trajectory of the field of PTSD? And just 2 specific things to point out, and then I'm going to open it up for the discussion. Number 1, some people are saying, if you look at the earliest writings about PTSD in the military and veterans context, much of it was about moral injury, like the Romeo Dallaire stories in the book. Much of it's about moral injury, so it's not a new construct for military and veteran PTSD, but that perhaps the field has moved closer towards, this is a question, the fear and anxiety, because there are specific evidence-based treatments that can address the hypervigilance in those symptoms. So that's one question. And the second one is that early PTSD, before it even was recognized in the military and veterans population, was in the area, I know me clinically, was in the area of adult survivor of childhood sexual abuse. So in all of our earlier work, working with individuals from that context, shame, guilt, they were all very much a part of a complex post-traumatic stress disorder. So can you speak to the field itself, the diagnostic criteria, and where do you think we need to be going in terms of, is it something that's included within PTSD? Has PTSD moved away from the guilt and shame component? Or what are your observations on that? Who would like to start?
Well, I'm happy to start, Patrick. I mean, I think you're absolutely right. The diagnostic criteria for PTSD changes, you know, from DSM-3 to DSM-4 to DSM-5. So certainly guilt was a component of PTSD, and then it wasn't, and now it is again. So I think that any diagnosis that's determined by a committee is influenced by a whole lot of factors that aren't necessarily just about the phenomenology of what people are experiencing. Some people will argue that with the DSM-5 criteria, which does have the negative alterations in cognition and mood, that includes the difficult emotions such as guilt and shame and so on, they will argue that therefore PTSD does now capture this broader constellation of symptoms. But I think that the dominant treatment paradigms for PTSD, particularly the exposure-based paradigms, are based on the fear mechanism rather than the moral injury mechanism. And so when we're working with people, whether we, the diagnostic issue is a little bit secondary to the person sitting in front of you and the range of experiences that they're telling you about and what you think you're going to be able to do to best help them.
I take what you've said very well. I think that from my perspective, there's pros and cons to looking at it as a diagnostic, as a diagnosable condition. I think on one hand, it bears some resemblance to and may be very well a part of PTSD or a component of it. On the other hand, the mechanism, as you've said, Andrea, is different, and so begs a different kind of an approach. I think there's issues related to self connection, attachment, relationships that really need to be explored. The roles that Brian talked about in terms of him being the person who he is with all of those roles that went and fulfilled his service and his duties, and it was him who experienced the injury and was going back into his world and his relationships. And so those pieces need to be mended outside of the role that one engages in as part of one's profession. So I think that there's a risk in over medicalizing a normal human experience of the who we are that we bring into the what we do, and the types of injuries that can be sustained in the course of any kinds of service that any one of us might do. Certainly there are those roles that lend themselves more, or people have more opportunities to be in those conflictual situations where the dilemmas are higher. But irregardless of what type of service we're in, we all bring the who we are into the what we do. And that's a normal part of human life. The struggle and the suffering is part of the fragmenting of relationships, the fracturing of trust. So there's the risk of, if we over-medicalize it, that the rest of the intervention, so to speak, the social connections, the community connections, the relationships, don't have as much of a place in a space. And in fact, they might be the very thing that's needed to be able to help people mend that. At the same time, depending on the source and the cause of it and the intensity and the degree to which someone is injured, certainly the expertise of the medical professionals, when trained and when able to recognize and have the right language and questions to be able to approach moral injury, that expertise is essential. Likewise, so is the expertise from a variety of different professionals, the spiritual care professionals, for example, or other community members that know that type of injury well, know the type of experiences people might be exposed to well, the language, and connect with that individual on a personal level. I think going back to it needing to be a very personalized kind of an approach.
I've heard it. Oh, sorry.
Go ahead, Patrick.
I was just thinking, I've heard it described by some that, and we've heard from veterans that this is very validating, that even traditional PTSD, I'll say the fear and anxiety based, are adaptive behaviors to the stimuli that, and then it's only when they come back in a different context that those behaviors can become maladaptive and really be functionally impairing their way of living. I've heard it described the same for moral injury, that all of the whole continuum of moral stressors and everything, if people can make sense of that, make meaning, it doesn't necessarily translate to functional impairment, but that when it does, it needs to be considered at the same level of valence. I wonder, Brian and Anthony, if you can speak to that from your perspective.
Anthony, go ahead. I'll follow you.
Okay.
Sure.
Sounds good. You know what, from my perspective, where we're seeing the shift towards a more fear-based, anxiety-based model of PTSD is really coming from the pharmacotherapy side of understanding what treatment is applicable for PTSD, right? Because we have animal models, we're able to derive pharmaceutical agents to remove those symptoms, right? In addition to other treatment modalities on the psychotherapy side. So that's one of the reasons why sort of this aspect of, you know, this the human aspect of shame and guilt and morality sort of took a backstage for a while. And I think now that we're seeing that in these populations where, you know, the classic anxiety and fear-based treatments are not working well, especially for individuals who have military-related PTSD as it's classically diagnosed. Now we're seeing, okay, well, let's dig in even deeper to understand why. And now we're seeing that, you know, it's not just those symptoms, and perhaps it's not just shame and guilt. There could be other emotions like anger, but it's really coming from a different source. And then just one more point that I wanted to make is, you know, and Brian, I think you hit it very well, that sometimes you can't just identify that exposure, that moral injury exposure. It could be over the years that eventually becomes this aha moment that, you know, this was a wrong that I witnessed. Maybe it wasn't at the time of, you know, the actual action was conducted, but years later. So morality is not static. It always changes across time. It changes based on the individuals who we interact with, our culture, perceptions of support. So I think that's where there's this difficulty that comes into understanding, okay, well, what is that PTSD trauma? What is that moral injury trauma? And a lot of times it does overlap. You have trauma that has some moral injury components, some morality components, but a lot of it could be fear-based as well. So it is sometimes a combination.
I would say that, you know, the military is very used to reporting, does a very good job of it. And when you look at how a military point of view would look at an event, and it would be able to write down the details, like exact details, how much gas was used, how long, this kind of thing. But the military also knows that it has to take stock of the situation, the situational awareness that they'll tell us. That is so much harder to write down in a patrol report. It's so much harder to say what our group felt was going on in this area, or the town didn't seem to like us that much. Why? But those are all mutually held feelings that everyone can in the room can nod and go, yeah, I felt that too. But could we describe to you what exactly that was? And I think the pain of moral injury is a lot closer to that second part, if you would look at it that way. For me, this has actually been an even more interesting process than I thought it would be, because one of the doctors that was critical in my healing, his name just came up in here earlier on one of the questions. So I kind of feel like I'm talking about myself to myself in that regard. But what I found was I found it easier to do group settings with professional help and get more to the base of what the problem was on the moral injury side, because even if I couldn't necessarily put words to the feeling, I would be in a room of 6 people that got it with a doctor. And that just helped more and was easier for whatever reason. I'll leave it up to professionals to put their finger on what that reason is, but that's how I felt. Whereas the one-on-one sessions, which I also felt were beneficial, were more beneficial at the traumatic events. That's how it went for me.
That's an interesting insight. And I think, as Andrea reminds us, you know, it's often very different when you move from the literature to the person in front of you. And Suzette, you always are focusing on the bigger picture and the more holistic approach. And can you speak to why you think maybe those things don't happen because they're maybe not as easy to do in a clinical trial? The more holistic approach.
It's harder, I think, just generally speaking, moral injury is like Jell-O in terms of trying to put our finger on it and finding out how to help one person, because it really needs a biopsychosocial, spiritual, holistic approach that's also socio-ecological. It needs to be both at the individual and at the family level, the community level, and the organizational level. So it is hard to do clinical trials on it. It's hard to, as Anthony noted initially, that we don't really have a definition of what we're talking about. So it's harder to measure what it is, and it has different sources and different routes for people. There isn't necessarily one person who is going to respond in the same way to the same event or the same exposure. And so it makes it more difficult to determine what type of treatment is better, how to assess it, and then how to do a trial on it. The symptoms vary. And I think it goes back to the earlier point that Anthony made in terms of where we are, and others have made in terms of where we are in the development and evolution of the study of it. Once we have some better answers, maybe we'll be able to look at those who have experienced more betrayals, or who have experienced witnessing of an event, or perpetrating an event, or having not been able to act in an event. So I think that there's different sources, and once we are able to distinguish that and how it applies to different populations, we might have a better sense of how to do some of the clinical trials, what kinds of treatments might work, and what kinds of interventions to use for whom, when. How much does prevention and preparation actually help to empower people, equip people to face those potentially morally injurious experiences? Does that help? We know we can't inoculate people from PTSD nor moral injury, but can we prepare and help people? Does that work? We don't know yet. There's certainly some research being done in that area. We don't know if early interventions are going to work, or what other types of issues people need to face that might predispose them to an injury. What type of personality might be more predisposed, what type of backgrounds and levels of resilience, whatever that means as well, might need to be looked at. So lots of questions.
Yeah, and I know, Brian, you've spoken about the resiliency piece in the training, and what could have happened differently. And with Anthony's work about all the different places that we can intervene. And I'm struck with what I hear a lot of people talking about, including within the healthcare context, is while it's going on, having someone as a sounding board to proactively have those conversations and the meaning making and all of that stuff. And Brian, having experienced it on a number of different deployments, what are your thoughts about the resiliency, the training, the prevention, the preparedness? I know you've given that some thought.
So this is one of the more exciting questions for me, because I think for the military personnel that'll be watching this, it's one of those moments of, here's a thing I can do about it. Because in the world of mental health, when you are not a mental health professional, you are limited in the areas that you can directly intervene. And one of the questions came up, and I really wanted to take a shot at this one. In the world of resiliency, I look at things like a deployment. I don't want to get moral injury just wrapped up in deployments, but I look at them and think, why is Canada there in the first place and not politics? But we're generally there because there's a societal breakdown. Things aren't working at a mass scale, right? And following that would be, well, there's a threat of violence or there is actual violence. So then the workable solution is to take Canadian soldiers and put them there. But even in that regard, the violence happening on your deployment is a possibility, and the societal breakdown that you're going to witness is almost guaranteed, right? And I think we train for violent situations remarkably well. We train on the prevention side, the handling, the action during, even the after action, and further prevention of more violent situations. We're really decent at that. Decent's the wrong word. We're really good at it. I'm not so sure that we are trained as well as we should on societal breakdown. I'll give you an example. Was my workup training, my first deployment to Yugoslavia, we did about 4 months of training for that mission, a couple of days of language, and about 1 4-hour period of having someone come in and speak to us about what it's like to grow up in Yugoslavia. And compare that 4 hours of what the society is like and what it's like now to the other rest of the weeks and months that you were preparing for attacks in mines. And I'm not suggesting for a second we do any less of that, which creates the military's dilemma and other dilemmas out there of you would train infinitely if you tried to train for everything. So it puts them under pressure, but I don't think we train enough for the societal breakdown. I don't think we train enough about the situational event that's happening. And my experience is that the moral injuries tend to be wrapped up in that.
So I'm wondering, Andrea, as you listen to Brian, I'm thinking you're clinical as well. And so a couple of thoughts is what have you learned most about the experiences of people that you've worked with that have described their own experiences with moral injury? And you can answer either of these questions you'd like, because the other question that came up is from Brian's perspective, given that the pandemic is happening internationally, what kind of preparation training for the breakdown? It's not a country's breakdown, but it's potentially a breakdown of a health system or whatever. What kind of lessons could we learn from what Brian's saying specifically to healthcare? So those are two different questions. You can take one or both.
And bearing in mind that it's 2 o'clock in the morning, my capacity to hold both of them. One thing I did want to come back to what Brian was saying that I find really fascinating, and that is the notion that the individual therapy was something that felt more right and helpful for the psychological trauma, whereas it was the group therapy that felt more important for the moral injury. And I think that that's really fascinating. Because it speaks to the nature of moral emotions, I think, in some sense, that they are essentially social emotions. So it's not about your personal survival so much as the survival of the group and the society, and how you experience those things and then come to, I guess, find a way of making meaning out of them in a way that restores a sense of connection with other people. So I thought, Brian, that was just really an important thing that you said, I think, and I think that we can really think about that, and I'll certainly be thinking about that when I work with other people. Other people who I've worked with have had very similar experiences of, when you put words to this sort of experience, there is that light bulb moment, and they just say, this is the first time I've spoken to someone who's had the right words to help me to validate the experience that I've had. So again, I think that's that validation, that sort of recognition from someone else about what you've been through is actually a really powerful part of the therapeutic process, and part of perhaps the beginning of people being able to start talking and coming to terms. I'm going to struggle more with your second question, I think, Patrick.
We can come back to that at some point.
Yeah, I think that's a really hard one to know. Even though we know a little bit now about this, I don't feel that we really know enough to be confident.
Yeah, and I know that one of the things I'm hearing from frontline healthcare workers is the most important thing is just seeing that their organization has their back, understands the complexity and the ambiguity in and of itself does a lot to support them in their work, just knowing that they're not alone.
And the general community as well, that they're being supported by the public.
Absolutely. And Anthony, I wanted to, so from your perspective, doing the research, doing the MIOS work and everything, with everything that we don't know about moral injury, what for you makes you most excited about this area and about making a contribution in the lives of veterans and their families?
Yeah, so I think it sort of relates to your previous question about, we've been talking about this issue for a long time. It was there for a long time. This aspect of moral injury It existed this entire time. Now it's being discussed, right? So it's almost analogous to a Pandora's box. We didn't know how to open it, and now we have so many questions, but I think it's really exciting and promising, both for individuals who are actually suffering from these issues, because finally we have a concerted effort from brilliant individual scientists, clinicians who are eager to solve this issue immediately, but doing it in the right process, right? So we can't really have treatments go in before we really understand the concept, but at the same time, we can't wait forever until we fully understand what moral injury is for us to actually intervene or prevent. We have to do our best because individuals are suffering now today. So lots of exciting domains. I think making a difference in an individual's lives, I think that's everyone's goal. And I think once we hear from the community who's actually experiencing this and getting their understanding of what works, what doesn't work, this definition really fits at the core of what I'm feeling, this doesn't. I think that's where we're going to make a lot of progress. And there are all these questions about, well, how can we create treatments when we don't have a very concrete definition of moral injury is? The thing is, each silo of a population of study has its own definition of moral injury, mainly because, when we're looking at military personnel, we sort of understand the scope of things that may cause those emotions or that aftermath afterwards.
Yeah.
But that may not be necessarily exactly what healthcare workers may feel, right? So now putting it together on one landscape really opens up the doors to more generalizable findings and more applicable findings.
And many are saying it's time for us to catch up to the phenomena that people are experiencing. We're running out of time, Suzette. I wanted to give you kind of the last word of kind of where you think, observations, maybe some of the potential and where we may be going in the future.
I think we're going into some places that Anthony just flagged in terms of defining the concepts, looking at assessment, finding out different kinds of interventions from a biopsychosocial spiritual perspective. And I think excitingly, we're in a time of great collaboration, because it's going to take all of us to be able to find ways to support individuals, to prepare individuals as well as organizations, and then to really work together to at a societal level. I think that COVID-19 poses us an opportunity as much as it poses us a challenge to bring the best of our expertise together to look at how we might be able to explore some ways to identify, to address, to support individuals struggling, and to help all of us prepare for any eventuality where any one of us might experience moral injury, and help us through these times of struggle. I think we're going to see some things related to the civilian population as well as our service providers, where individuals might be have been experiencing moral injury without really realizing it. Our caregivers, our family caregivers, spouses and partners of those who are struggling, children who are struggling.
Mm-hmm.
So there's much in the way of recognition, of pulling together, bringing the best of our expertise together in a collaborative and holistic way to provide the supports and services that people need. So lots of exciting things from my perspective.
And as I said to Dave Pedler, we could have 2 days on this rather than 2 hours, and we probably will in the future, because there's so much to do, and there's so much excitement, and kind of our veterans and our first responders, they're ready for us to really lean in and engage in this and make better meaning of it. So I want to thank all of you, Anthony, Suzette, Andrea, Brian, for this amazing panel. It's not a one and done, it's a beginning of many. I want to thank all of the members of the Canadian community of practice on moral injury. We have a lot of great people doing a lot of great work across the country, and our international partners in the Five Eyes countries and others, and special shout out to the Phoenix for such an amazing partnership. I also just want to reiterate our thanks to all the veterans and family members who are tirelessly giving of their stories, their experiences, and their insights, so that we can kind of step up to the plate. The gauntlet has been thrown out, in my opinion, by those individuals with these lived experiences, and it's up to us to catch up to measuring and coming up with better ways of supporting them in a holistic way. So a huge shout out to CIMVHR for their work once again. And I think Dave Pedler, head of CIMVHR, is going to also share with us his closing remarks.
We look forward to collaborating with you and your team in the future. Doctors Nazarov, Ramo Phillips, and Associate Professor Phelps, your expertise in this area has been heard today. We appreciate all of you dedicating your time to this symposium and educating our audience on the current understandings, gaps, and future directions of moral injury. Mr. Mckenna, thank you for your bravery to speak to us about your experiences, and most importantly, thank you for your service to Canada. I want to thank our symposium sponsor, True Patriot Love Foundation. We're grateful for your continued support of CIMVHR and your commitment to advancing health research that will benefit our military personnel, veterans, and their families. Please visit the Moral Injury Symposium website to see a video message from Mr. Nick Booth, CEO of True Patriot Love Foundation. To all of you, I hope this symposium series has been educational, thought-provoking, and inspirational. Let's continue collaborating and pushing the research forward so we can serve those who serve us. Thank you.